Okay, so this has actually quickly become my favorite part of being the on-call attending. You guys are so far away. It's so lonely over here. I actually have really come to enjoy this part of it. This is something that we weren't doing previously, and it's kind of fun. Today we're gonna talk about the colon. You know, the one caveat is I am not, technically speaking, a colon surgeon. I do a fair amount of colon surgery, but I never ask for it. You know, colon, it's an important structure, and in surgery we come across it a lot. And the colon has this knack for sort of breaking your heart. I mean, there are a lot of general surgeons out there who actually decline to operate on the colon. And there are some very, very good reasons for that. I am not one of them. I actually, I do enjoy colon surgery, but it is fraught with peril, as one of my attendees used to say. So we're going to talk about colon. We're recording this as before for the benefit of our night resident. I hope. Welcome to South Campus. Have a good month. It'll be fine. It'll be over before you know it. So let's start with, where's the colon? Is that true?
In the abdomen. Part.
Is that true? Yeah. So the colon is, yes, it's in your abdomen. And it is the tail end, no pun intended, I actually meant to make that pun. It is the tail end of the intestinal tract. And, you know, the important place to start when talking about colon is the embryology. So what are the three different layers of the primitive human being? So
Ectoderm, mesoderm, and endoderm.
That's right. And so of those three, which layer goes on to form the gut in general, the GI tract? Second?
Endoderm.
It is. It's the endoderm. So it comes from the primitive endoderm, right? And what are the components of the gut?
Foregut.
Foregut. And what are the boundaries of the foregut? Starts the mouth. Where does it end? Ends at the end of the first. So the second part of the duodenum, D2, is the start of what?
The midgut.
The midgut. Midgut goes to where?
From there to, is it the cecum? Or does it?
Nope. Do you guys know? Yes, it's the transverse colon. But where in the transverse colon? So it goes to the distal 2/3 of the. Okay, very good. I'll give her credit, Mandy. You get credit for it. And then what's the third segment?
Hindgut.
Hindgut. Okay, and hindgut goes from the distal third of the transverse colon to
the callus, to the anus.
I'm going to take you to task. Is it the anus?
The anus is ectoderm, right?
So then is it the line?
Dentate line.
That would be my second guess.
So I mean, this is obviously under there's controversy, as you know, those colorectal surgeons, they just love to argue. So the rectum is definitely part of the hindgut, at least the anterior parts of the rectum, right? What ultimately forms the anus and the anal canal and the urogenital tract? What is that primitive, in the primitive state, what's that called? Cloaca, that's right. It's called the cloaca. And the cloaca is comprised of both endoderm and ectoderm. So let's write foregut. Okay. What's blood supply? Primary blood supply to the foregut. Celiac artery, good job. All right. Midgut.
Super.
That's SMA. And then what's the predominant for the hindgut? Oh, for Pete's sake. IMA. That's right. Okay, so this is all important, right? I mean, it has real relevance in terms of how we do our, has real relevance in how we do our resections. So our colonic resections largely follow the blood supply to the colon. So how is, anatomically, how is the colon, the hindgut? Well, so the colon and the rectum, how is it broken down? What parts are there of the colon?
Cecum.
Okay, hold on. Let me erase my scribbles. All right. So the very first thing you come to in the colon, you've already said, is the cecum. Okay. What's next? What do we call that?
The appendix is hanging off.
So the appendix is hanging off the cecum. We'll talk about that in a little bit. Okay. So after the cecum comes ascending colon, right? And so in general, we consider the cecum part of the ascending colon. If you tell someone you're doing an ascending colectomy, usually means you're taking the cecum as well. So, so ascending colon. How big is the cecum?
Couple centimeters? 5-6 centimeters?
So it averages about 7.5 centimeters. Okay. When do you start worrying about perforation of the cecum?
So he doubled that.
So we just say about 12 centimeters, but you got to be careful. So if the cecum dilates acutely, it can perforate as low as 10 centimeters of dilation. So not a lot of give the cecum. The cecum's very thin-walled, and has a tendency to perforate when it acutely distends. Okay, so how long is the ascending colon? Any guesses? You think it's really long, don't you? It's actually not. It's about 15 centimeters. We credit about 15 centimeters, which is not much, right? Yeah, not much at all. So after the ascending colon, what do we got? Transverse colon. Okay. And then what follows the transverse colon? Descending colon. What follows the D? And how long is the transverse colon?
There's your
Okay. So descending colon. How big is that?
25.
Good job. Nice. All right. What follows the descending colon? Sigmoid. And so the sigmoid is highly variable, right? I've seen sigmoid colons that are just, 10 centimeters and, just sort of squeaking through the pelvis. And I've also seen sigmoid colons that, yes. So, but the mean length of the sigmoid colon is going to be about 38 centimeters. That's the mean length. So in general, sigmoid colon tends to be long, but it runs a full spectrum. It doesn't have any particular size limitations that it adheres to. So, what is kind of a more convenient way that we sort of break this down as surgeons in terms of anatomy? Do you ever really hear a surgeon say, "I'm going to go do an ascending colectomy"?
It's by the blood supply, right?
It is, and so how do we sort of compartmentalize? Really, three different.
The splenic flexure is sort of where the IMA starts. Is that right?
Yeah, so that's a watershed area, right? So if we were to draw the colon, you got your cecum down here, you got your ascending, makes a right turn at the liver, makes a right turn at the spleen, comes down here, becomes the rectum. We'll reverse this. Okay, and then of course you've got your terminal ileum comes out there and your appendix that comes out here, okay? So, so as surgeons, we sort of compartmentalize them into three different components, right? What are those components? Come on, Will. Right, left, and so help me out. What's a right colectomy?
So you basically take part of the terminal ileum, the cecum and ascending colon, and part of the transverse colon up to the point of the middle colic artery.
So you would usually, so if the middle colic artery is coming up like this, there's a branch that comes out that calls the right branch of the middle colic artery. Mm-hmm. So we're going to leave that or take that?
We're going to take
We're going to take that, right? So that's your right colon, right? So what's the left colon?
Left colon is, I guess, to the left of the middle colic artery.
Right.
And up to the, I guess where the sigmoid.
Right. And then what's the third component that we sort of arbitrarily break it down into?
So basically we're the distal end of the descending colon up to the kind of the peritoneal reflection, or the rectus reflection.
That's right. So what are the three different landmarks that we can use that we use that tell us we're at the end of the sigmoid? Where does the sigmoid become rectum? Three different landmarks that historically have been used. What's number one?
Sacropromontory.
Sacropromontory.
And then
that's a useful one.
The splaying of the tinea.
Okay.
I'm trying to think of the pelvic brim. It's kind of sacropromontory, I guess.
You said pelvic. No.
Is that not one?
It's not pelvic brim. So the pelvic brim is this boundary, right?
Oh, okay.
That's pelvic brim. So the start of the sigmoid is pelvic brim.
Uh-huh.
So sacropromontory, splaying of it's peritoneal reflection. That's right. All right. So in general, these three things give us a sense of what is the where the true end of the sacropromontory of the sigmoid colon is, right? We call that the rectosigmoid junction. So, just a little bit of a side. What's an extended right colectomy?
Take it to the left of the middle colic artery.
That's right. So you're getting about 2/3 of the transverse colon, right? Mm-hmm. And it's just the opposite for an extended left, right? So extended left is going to be 2/3 this way. So so occasionally we'll get a tumor in this area or in this area where it doesn't quite fit the anatomic pattern for a true right colectomy or a true left colectomy. We do something called an extended left, and that's where we take our boundary either to the left or to the right by just a touch. So that brings us to the appendix, right? The appendix is our friend until it's not. Okay. So Amanda, how do you find the appendix? Well, we usually call it making an incision. We don't usually say cutting people open. But how do you find the appendix? No, man, you seek them. I should have kept that one to myself. Okay, so it turns out that of the parts of the colon, the thing that is most consistent is the location of the appendix. So the appendix is typically 3 centimeters inferior or below to the IC valve, right? What's the IC valve? The ileocecal valve, right? It's what prevents reflux of succus from the cecum back into the terminal ileum. Sorry. Second, what's the second reliable landmark for the?
Can you trace the tinea?
You can. So it very, very reliably occurs at the convergence. So we already talked about the splaying of the tinea coli. It very reliably is located at the convergence of the tinea coli. I am not at all sure I spelled that right. Looks pretty close to me, though. So what is sort of the third surgical landmark we can use? Absolutely useless, but I ask every medical student that scrubs with me on an appendix. Anyone ever heard of the Vale of Treves? Anybody ever heard of that? What's the Vale of Treves?
Piece of fat
Piece of fat.
hanging off right there at the terminal ileum.
What's unique about the Vale of Treves?
You can visualize it. It's not part of the. It's a piece of fat not involved in the mesentery.
So it's an epiploic appendage,
Right.
right? Where do we usually see epiploic appendages? We usually see it on colon, right? So the Vale of Treves is the only place on small bowel where you can reliably see an epiploic appendage, right? The rest of the small bowel is devoid of these epiploic appendages, which are all over the place, all along the large intestine. So that's a very useful landmark that we can use. Fun story: when I was a young attending, I removed what looked inflamed, and for the life of me, appeared to be the inflamed appendix, though not perforated. And the guy got better. Sent him home the next day. He was feeling great. Yeah, great. You fixed me, doc. Got a call from pathology yesterday or the next day that was fat. That there was no appendix in there, man. And it turns out I had just removed the Vale of Treves. So he got better. You know, I did have to then go back and addend his op note saying pathology on this was fat. It would appear that his appendix is still in place. And the reason for that is because insurance companies will only pay for one appendectomy. So if he comes back with appendicitis, that doesn't get paid for, right? Because the insurance company says, hey, you only have one appendix, you only get one removed. So it actually ended up being a bit of a headache for me. So what is the what does the colon do? What is the importance of the colon? What is its function? What is its job?
Use of water.
Right. So in general, let's go back to the appendix for a second. So while the base of the appendix is very, very consistent, the location of the tip is not. And remember, that's something that's predetermined by embryology, right? Because there's something called the mesoappendix. So where the tip of your appendix lies, that's actually something that's determined by our genetics. So what's the most common place for the tip of the appendix? And this makes a difference because if you examine somebody, whether or not their exam is consistent with appendicitis is going to largely be dependent upon where the tip of their appendix is, right? So what's the most common location for the tip of the appendix? Tom?
Is it anticecal?
It's actually retrocecal. So retrocecal, about 65% of them are retrocecal. Okay? And there's a maneuver or how do you suspect somebody has appendicitis? This doesn't make that much difference anymore. It used to be, we didn't have things like CT scans that we could, and when I was training, our CT scans weren't great. So we learned to not really trust them. And in fact, I was taught, up until about my third year of residency, I was taught if you don't have a 20% negative appy rate, you're not operating enough. In these days, I don't think anyone would tolerate a 20% negative appy rate. I don't think many people would tolerate a 5% negative appy rate because the CT scans have gotten pretty good, right? So if somebody's retrocecal, what are the things that you can do to provoke their appendicitis to give you a good sense of?
You can do a psoas sign.
Psoas sign. What's a psoas sign?
So you can, so if you extend their hips
Uh-huh.
up against their psoas, it won't irritate.
Yeah. It's the other thing you can do.
You can do
So I think that's didn't think it too much. Okay.
So for the sake of the video, what Tommy said is you could do it. You could test for psoas sign, and that's essentially where you straighten the leg and you raise the leg. That's going to engage the psoas muscle, which will irritate the inflamed appendix and cause them pain. So it has to do with where you're going to do your exam. It's the other thing you can do.
You can do you can press on their left lower quadrant, which pushes all of the abdominal contents to the right side, and that'll irritate the appendix.
What do you do with, so you're doing your exam with your left hand, what are you doing with your right hand?
You're pushing the appendix into your left hand.
They don't do this anymore. You do a rectal exam, right? So you do a deep left-handed palpation while doing a rectal exam. The idea being that you're irritating the appendix, and I don't think I've ever had to do that. Most people with appendicitis, I can't imagine they appreciate you doing a digital rectal exam. It's like the worst day ever, right? You know, I got appendicitis. Somebody stuck their finger in my rectum, and I would. Maybe this was why they used to teach if you don't have a 20% negative API rate, you're not operating that, because nobody wanted to do that digital rectal exam on somebody with appendicitis. So in general, the physiology of the colon is that it captures all the nutrients that the small intestine misses. And so, what are the two most important? Two most important nutrients that the there's water. So water is the first one. We're sort of putting water in the nutrient bucket. And then, and how much of our water does it typically resorb? So water absorption.
A liter?
It's about a liter. Yeah, it ends up being about a liter. And so it's largely dependent on how much water you drink. So if we're to talk about in terms of percentages, about 65% of the water that we consume gets absorbed by the colon. So stool that enters the colon or the cecum from the small bowel, is it liquid or solid?
Starts out as liquid.
It's liquid. So succus is liquid when it's in the cecum. By the time it gets to the rectum, is it liquid or solid? It's supposed to be solid unless you've got some sort of GI upset or whatnot. So about 65% of the water that we intake is taken up by the colon. So the other important one that the colon uptakes is sodium, right? So sodium is another important one that's resorbed by the colon. So about 5% of our bile salts get reabsorbed in the colon, right? It does a little bit of absorption of a whole slew of things, but by far the most important ones are water and sodium. And what are the three things that determine how effectively the colon is absorbing? Three different factors that are super important. Transit time. So colonic motility. So that's, let's not write that down. So colonic motility is hugely influential into how efficiently the colon resorbs. So if stuff's moving through fast, it's coming out diarrhea, right? You go to San Francisco, you eat that sourdough that was cooked in some wharfside bakery, and all of a sudden, 30 minutes later, you're in the toilet, and it's because that transit time is increased, right? What are the other factors? Probably related, not what I had in mind. So it's actually highly dependent on flora, right? We have bacteria that live throughout our colon that we depend upon for the health of our gut. And some things can't be absorbed. Some things have to be broken down by bacteria before we can actually absorb them. So it's largely dependent on the health of our biome, our personal flora. So what's the third factor? So it's the health of the mucosa, right? It's how how functional is the mucosa behaving. So those three factors are what determine the absorptive capacity of our colon. And so let's talk about the flora for a minute, because the gut flora fascinates me. When I was early in my residency, what did we used to tell patients about their appendix? We have to go talk to a patient. You got appendicitis. We need to take your appendix out. What did we tell them about their appendix? It said it's useless. It is a vestigial organ. It doesn't do anything. You'll never miss it. That's probably true. I had my appendix out when I was 19. I've never missed it, but is that true? Do we say that to patients anymore? So what are they teaching you guys now? I'm interested.
It has an immune function.
It does, right? So what are the two things we know about the appendix? It has a high concentration of...
It's rich in lymphoid tissue.
I'm off camera, so... It has a high concentration of two things.
Lymphoid tissue.
Lymphoid tissue.
And
What's number two?
Probably flora.
Bacteria, right? So what do we now think is the role of the appendix? Why have we retained it? If it was useless for millions of years, why have we retained it?
Is it a little safe haven for your flora?
That's exactly right. So there is increasing evidence that it is the responsibility of the appendix to maintain our fingerprint. So everyone's biome is specific to them. So the concentration of the different bacteria that live within the biome, or live within the colon, are specific to each individual. And so what we think is it's the responsibility of the appendix to maintain a fingerprint, so that when that flora is disrupted by diarrhea or antibiotics or whatnot, it's the responsibility of the appendix to then take your specific mix of flora and repopulate your colon with the flora environment that's healthy for you. So that fascinates me. Actually, Susie Klaus did her PhD in gut bacteriology and actually ran this bio, and she said that's actually about right. So it's not exactly what she did her dissertation in, but that concept just fascinates me because, again, my first 3 years of residency, I probably told 500 patients, we're about to take out your appendix, and you don't need it, don't worry about it. It turns out I was wrong, which wouldn't be the first time. So, but there are actually about 400 different types of bacteria that live in the colon in healthy individuals. And the microbiotic mass is so large that it actually comprises about 50% of the weight of fecal matter. So imagine that, 50% of the stuff that you produce, 50% of that is bacteria. So just keep that in mind the next time you don't wash your hands after you have a bowel movement. So most of them are aerobic, anaerobic. Say again?
Anaerobic?
Anaerobic, that's exactly right. And what's the most common species?
E. coli?
You'd like to think that because that's what seems to get everyone infected. It's actually not. Say again? Bacteroides, that's right. So about 2/3 of the composition in the colon is bacteroides. More than 70% in the rectum is bacteroides. So there are four main subtypes. E. coli is one of them. There's bacteroides. Let's see. And so, what are the functions that those bacteria do for us? They have actually several, right? What's the most important thing that they do for us?
They occupy the space so that other more like nefarious bugs don't. Right? Isn't that
You just
part
made that up, didn't you?
No,
Okay.
It sounds right.
It makes sense, right? So there is definitely an immune function of your microbiome, and that is probably a mechanism. It's not the most important. So what is the primary energy source for your colonic mucosa? What do they live off of? Short chain fatty acids, and there's one specific. You already said it once today. we were walking in the hallway in between the ER on our way to the elevator, and anyway. It's butyrate, right? It's butyrate. So butyrate is a short-chain fatty acid. It's actually the primary energy source for the colonic mucosa. So the colonic mucosa is different from the rest of the GI tract because the rest of the GI tract, the entire organ, depends upon the blood supply, native blood supply to receive its nutrition. Primary nutrition for the colonic mucosa doesn't come from the blood supply at all. It comes from within the lumen. It comes from the butyrate that is manufactured by bacteria. How do bacteria manufacture butyrate? It's a product of what process? How come you can have that beer? How come people like that beer so much? Fermentation, right? So, what is getting fermented? What is the substrate that makes that ends up in the butyrate that then feeds our fiber? Yeah, fiber, exactly. So that's by far the most important function of the bacteria is to do exactly what they do, is to live off of the fiber that we eat, make the butyrate that feeds our colon, right? Another short-chain fatty acid then it's called acetate, right? Gets absorbed, gets sent to the liver, and what is acetate the building block for? For cholesterol. Acetate is the base molecule for cholesterol. So all these things, it turns out, very, very important that what this microbiome does for us, right? Let's see. So we talked about immune function. So in order for the basement membrane attachments to be healthy, so that we don't have these bacteria gaining access to our bloodstream, that's dependent upon a healthy mix of this flora in our colon. Again, this stuff fascinates me. This was not stuff that I think I probably learned about it in med school, but I don't know, maybe I was sleeping that day. Incidentally, somebody who's had a colostomy, or somebody who's had let's go with a Hartman's, they've got an end colostomy, they end up with pouchitis, right? So the Hartman's pouch keeps getting inflamed for so we'll try them on antibiotics several times, see if we can get rid of, right? But what's the ultimate solution for that? Short-chain fatty acid enemas, right? So what can often make that recurrent problem go away is you actually do enemas with short-chain fatty acids, and that can alleviate the symptoms of the proctitis. So really, it's all starting to come together, right? What is the end product of fermentation? So we've got short-chain fatty acids, primarily butyrate, makes two other products.
CO2 and alcohol.
Methane. What's the other one? So methane's taking that oxygen. What's water without oxygen? Hydrogen, right? So the three products are short-chain fatty acids, methane, and hydrogen. So why can people light their farts on fire? I've never tried it. Okay, maybe I've tried it. I've never been successful. It's because of the methane content in their farts, right? So about 50 to 75% of expelled gas is actually gas produced by bacteria, right? The other 25 to 50% is air that we swallow. Let's see. So let's get into some specific diseases. All right. So let's start with diverticular disease. Okay. What are diverticula? What's diverticular disease?
Outpouching of the descending colon.
Just the descending colon?
Oh,
What if they have in the ascending colon? They're not diverticular?
I guess they can be.
Yeah. So you can get them. You can get them anywhere. They are more common in the descending colon. So why do they occur? What is the pathophysiology behind the formation of diverticula?
to increase pressure in the lumen.
Highly related to pressure, right? Which also explains why it occurs more commonly where? Where's the most common place to have these diverticula? Sigmoid colon. Why is that? Yeah, maybe part of it. So if you're constipated, that's where the pressure is going to be built up, right? With that big clot of
That's
desiccated
the vault.
poop.
That's the vault where stool sits for the longest amount of time, so there's like relatively constant pressure there.
Maybe true. Has to deal with physics. I want you to go all the way back to your undergraduate physics class.
Science.
No, it's a law.
It's a law. Two laws. Both of them apply, right? So Laplace's law tells us what? What is Laplace's law?
Oh, surface tension one with radius.
So it applies to a sphere, it also applies to a tube. So Laplace's law is pressure within a tube is inversely proportional to lumen size or radius, right? So what does that mean? That means the smaller the lumen size or the smaller the radius, the higher the pressure, right? So sigmoid colon, is it small lumen compared to the rest of the colon, or is it large lumen? Small lumen. Why is that?
Space.
It's got less space. It's trying to go through the pelvis. Everything has this great big abdomen to live in, but the sigmoid has to pass through the pelvic inlet and eventually, through a very small space. So the lumen of the sigmoid colon is much smaller. So what is? I'm going to totally hammer this one. Poiseuille's? What is Poiseuille's law? It's an equation, right? So what does that tell us? So delta P, change in pressure from one end of the tube to the next, is equal to, I'm going to write it out, because there's no way any of you have this memorized. So 8 mu
And then R to the 4.
L, which is length, mu and Q are constants, over pi R to the 4th, right? So what does that tell us? That not only is it dependent on the size of the radius, it's actually exponential the smaller you get, right? So if you cut the radius by half, you've just increased the pressure by half to the 4th, right? 2 to the 4th, right? So not only is it proportional to the size of the radius, that effect is massive. It by far is the most important effect, such that you can forget about these constants in calculating this delta P, right? Because it's that effect it has such an influence. What is the incidence of diverticular disease? Pretty high in America, right? We like our iron-rich foods, and we hate our fibers, and we don't eat our leafy greens. So pretty high. So what's the incidence? Anyone know?
20%.
Just across all comers? It might be true. So in folks older than 60, it's about 30%, right? About 30% of the population has diverticula. In folks that are older than 80, it's as high as 80%. So it's it's a huge problem. That about 10 to 20% of people with diverticula end up with some sort of symptom from those diverticula, whether it be bleeding, whether it be diverticulitis, and that results in about, last year was about 300,000 hospitalizations, and a whole slew more that didn't have to be hospitalized for their diverticular disease. But it's a big problem, right? So let's talk a little bit about the anatomy of a diverticulum. Where do they occur?
Pouching of the mucosal wall is it has all three layers of the wall.
Does it? Do diverticula
It occurs where
have all three layers?
it occurs where the vessels.
The perforating vessels, what do we call those?
Sorry, this is pretty good.
What do you call them, Ruel? I know I totally broke the rules. I'm supposed to go down in seniority. I'm not supposed to go up in seniority. It's the vasa recta, right? So they occur at the vasa recta. And so where do you find them? With respect to where on the colon, where do you find them? Mesenteric or antimesenteric border? Where's the blood supply come from? Mesenteric border, right? So you typically find them on the mesenteric border, right? So it's a natural weakness because you've got a penetrating vessel, and that implies what? Are all three layers truly involved?
I guess not.
They're not, right? So diverticular disease in this context, these are actually pseudo-diverticula. They typically involve only the mucosa, so they are not true diverticula. We call them pseudo-diverticula. But it also describes, or that explains why they have a propensity to rupture. Let's see. And so, how do we manage diverticulitis? So you guys, you've met our patient upstairs. We got to start by. It depends on how we classify. It depends on what kind of diverticulitis they have, right? So, broadly speaking, how do we classify diverticulitis? The very first question when we hear somebody with diverticulitis, the very first question is it complicated or uncomplicated? That's right. So what are some of the complications of diverticulitis?
Blood in the stool.
So bleeding. Bleeding is definitely a complication. Abscess. Yeah, abscess is definitely a complication. Another complication? That usually comes from abscess.
Perforation.
Perforation, so abscess usually implies perforation.
Stricture.
Stricture, we have a special name for that. We call that a diverticular stricture. That's a bigger problem than many people think. What are the other complications? One more big one. Fistulas, right? So what's the most common fistula to form after? First of all, what's a fistula?
The epithelialized tract between two women.
That's right. That's exactly right. So, and so what's the most common fistula that results from diverticular disease?
Blood.
That's right. Colovesicular fistula. More common in men or women?
Men.
Why?
Pretty extent on closer.
The uterus is blocked.
The uterus. That's right. So colovesicular fistula is the more common fistula to be formed as a complication of diverticulitis, and it is definitely more common in men. And the reason is because women have a uterus that sits right in the middle and obstructs. Women get what kind of fistula? If the uterus is sitting right there, right? So they'll get a colovaginal fistula. You can get a coloenteric fistula. What's a coloenteric fistula? So it usually goes to small bowel. That's a big deal, right? Those patients get profoundly malnourished because of those fistulas. Those are a big problem. What are the other fistula you can get? Yeah, colocutaneous fistula. So that's a big problem, right? So you've got complicated, you've got uncomplicated diverticulitis. So somebody comes in with left lower quadrant pain, they've got a little bit of fever, maybe their white count's 13. Get a CT scan, you don't see any of these complications, and not having any bleeding. There's no reason to think they've got a colovesicular fistula. How are we going to manage that person? Yeah, we're going to give them an antibiotic. I don't know unless you read that paper that you pulled up. You can just send them home, wish them well, and hopefully good luck with that, buddy. Most of us would give them a course of PO antibiotics, and what I was taught is 10 to 14 days of PO antibiotics. What do we counsel them on regarding low diet?
More fibrous foods.
So after 6 weeks, right? But in those first 6 weeks, what do we want them to do? Low residue, low fiber diet for the first 6 weeks, and then when you assume they've recovered from that bout of diverticulitis, you then have them increase their intake of water and fiber, because it was the low fiber diet that got them into trouble to begin with, right? So you've got uncomplicated diverticulitis, you've got complicated diverticulitis. Somebody comes in with complicated diverticulitis, and let's say that complication is an abscess, right? So-called perforated diverticulitis. So when I was a resident, we didn't have this thing called microperforations. We're hearing all these times, all the time we're hearing about these microperforations, and everyone sounds alarmed. Call surgery, tell them to mobilize the OR, so microperforations are probably a product of our CT scans getting better, right? Back when I was an intern, this is 2006, they were probably having microperforations, but our CT scanners were 64 slice or 68 slice or whatever, and they just couldn't pick up these microperforations. We can see them these days, and so when I get this call about I've got Doc Wiseman, I've got a patient with diverticulitis and microperforations. Where do you want me to admit him to? Send him home. That is uncomplicated diverticulitis, right? So you've got complicated. So doc calls you, ER doc calls you and says, "Hey, got a patient. They've got an abscess, presumably from diverticulitis." So how do we classify perforated diverticulitis? What is the classification system? The Hinch's classification. What are they? What is Hinch's classification? Got to get it on video.
There's
4.
things.
Yeah.
One is,
What's Hinchy 1?
it's like contained.
So contained abscess, and it's dependent upon the location of that abscess, right? So where does that abscess have to be in order for it to be a Hinchy 1?
Around the mesenteric?
So pericolonic or mesenteric, right? It's essentially not within the pelvis itself, right? So Hinchy 2. What's Hinchy 2?
The pelvic one.
So pelvis. So contained abscess, not local to the colon, but within the pelvis. What's Hinchy 3?
That one's peritonitis. And
So
4
3 and
is
4 are peritonitis. So what's 3? What kind of peritonitis?
Not feculent, but
Purulent
purulent.
peritonitis. That's right. So there's pus all over their belly, but no stool. And what's 4?
Feculent.
It's poop. They got poop all over their belly, right? So you come across somebody, with perforated appendicitis. What is the very first question you're going to ask that's going to determine what you do next?
How many days and if there's an abscess? Well,
They told you there's an abscess.
oh, okay.
So your very first question is operating room now or not operating room now? What is the first question that's going to help you decide whether or not you need to go to the operating room right now? Stable or unstable? You're going to ask about vitals. Okay, what's the heart rate? What's the blood pressure? So let's say blood pressure 78/50. Gave him 2 liters. It doesn't seem to be coming up, right? What's your move? You're going to the operating room, right? You've got no choice. This patient is fluidically septic, and moreover, they're beyond fluidically septic. They're actually now in septic shock from their perforated diverticulitis, so there's no choice. You're going to have to operate, right? What's the opposite of unstable? Stable. So now you have a choice, right? So now it's going to be largely dependent upon the characteristics of that perforation itself, right? So what is, so Hinchy 1. What's the very first thing you're going to tell that you've established patient stable? What's the very first thing that you're going to tell that ER doc to do? Or you're going to do it yourself? What are you going to give them? You're going to give them antibiotics, IV antibiotics. It's more specifically broad spectrum antibiotics, right? What are you going to take away from them? You're going to take away their food. Can't eat. Sorry. Nothing by mouth. Because I'm not sure I'm not going to have to operate on you, right? It's the third thing you're going to do.
Food?
Tommy spent all afternoon after our case doing this. You took a colon IR, right? You're going to figure out a way to get that abscess drained, right? You want to get that pus out, right? So this is probably true for Hinchy 2 as well, right? So in most cases of Hinchy 2, this is going to be your move. Becomes a little stickier in Hinchy 3, right? Right. So what do you do with stable Hinchy 3? So, this is probably the area of most controversy in diverticular disease, right? So there are some people that say you put a camera in them, you wash them out, right? You leave a drain, you leave the colon alone, right? And then you get out, you wait for them to get better, and then you come back later after you've done a colonoscopy. You do their sigmoid colectomy. What's the other option? What's the other surgical option? Hartmann's procedure. So what's a Hartmann's procedure?
Sigmoid colectomy and colostomy.
That's exactly right. That's all you need to. So if an attending asks you what is a Hartmann's procedure, we are looking for 4 words. 4 words. We're looking for a sigmoid colectomy and colostomy. And sigmoid colectomy and colostomy. Sorry. And that's all you need to say. So basically, you're leaving a rectal stump. You're taking out the diseased colon. You're leaving a rectal stump. You're going to bring up an end colostomy. Take it out. Is there another surgical option? What's that, Richard? So you take out the sigmoid colon, put it back together, and give them a diverting loop ileostomy. Or I suppose you could just give them a diverting loop ileostomy and leave the sigmoid colon for later. That would also be a reasonable option. What's the theoretical advantage of doing the ileostomy?
So they're easier to take down.
Heck of a lot easier to take down. They're a lot more forgiving than the colon, right? The worst thing in the world is to take down an end colostomy, put it back together, and have them leak. And what do you got to do?
Put it right back up.
You got to put it right back up. That's awful, right? So, been a while since I've done a true Hartmann's, but I've thought that maybe because a paper just came out on this that was presented at American College of Surgeons last year, where they found equivalent outcomes. And there's a higher rate of ostomy reversal if you give someone an ileostomy. Why is that? What are the downsides of an ileostomy?
High output.
High output, right? So, and that output is liquid or solid? It's liquid, right? So you get people who are putting out 1,500, 2,000 cc's a day. Suddenly they come in a week later and their creatinine's 2.7, right? You got to hydrate them back up. So in the elderly who tend to be the people who get this tend to tolerate ileostomies the least, right? The younger people, though, I far prefer ileostomies, just because number one, they can keep up with the PO intake you need to maintain an ileostomy, and number two, it more of a guarantee, or they are more likely to actually proceed to take down. The problem is you do a Hartmann's on somebody, they've got an end colostomy, for whatever reason, a lot of those people tend to get lost to follow-up, and they end up with the rest of their lives with a colostomy. So lots of theoretical advantages to a loop ileostomy. Plus, you're in the meantime, your colon anastomosis is healing, and it's healing in an environment where it's not receiving throughput. And that, obviously, they might leak, but you're never going to know about it, right? Before you take that person down, you're going to do a contrast study from below. You're going to make sure that your anastomosis is healed. So, okay. We only have about 5 minutes left. I'm pretty pleased because I wasn't sure I had enough. So I want to talk about volvulus, and the reason I want to talk about volvulus is we had a case of this. I think you guys weren't on service, but we just had a case that it's worth knowing the difference. Can we turn on the? They booted me.
There's
So what is?
saw him in clinic today.
Oh yeah, you saw Pal?
Oh, this is actually a different.
Oh, you're talking about
The TBI guy.
Yeah. So he had a volvulus?
He had a valgus and he had a cancer.
I know, a bad one too. All right.
So this is the directory that I gave you guys resent.
This is the guy. Well done, Tommy. Well done. All right. Yes, I have some pictures that I want to show. So what's a volvulus? What's a volvulus and where can it occur? Tommy.
A volvulus is twisting.
Twisting.
About
Okay.
at a fixed point, and it can occur anywhere where there's kind of like a loose or a very long mesentery. So classically, you can have like a cephal volvulus
Okay.
or like a sigmoid volvulus.
Okay. That's right. And it's a surgical emergency, right? You got to get that unvolvulated because it's a twisting, right? And it's not just the colon that's twisting; it's the blood supply to the colon that's twisting. So not only is that colon, that lumen of that colon occluded, it's also dying, right? It's becoming ischemic and it's going to infarct. And the two places that's most likely to occur are at the cecum as well as the sigmoid. So how do we manage that?
So with the sigmoid, you want to, so if the patient is stable, you can have GI do endoscopic decompression,
Mm-hmm.
and then you can bowel prep them, and then bring them to the OR. If they're unstable, or if GI is unable to decompress them, then you would bring them to the OR, and then do a heart-release procedure, and then put them back later on. If it's a cephal volvulus, then generally you would bring them to the OR and do a resection.
That's right. So the answer was you would do, for a sigmoid volvulus, you would do if they're stable, you can have them endoscopically decompressed. Oftentimes GI will leave a rectal tube to try and, because you've got a floppy sigmoid, right? So they'll leave a rectal tube to try and reduce the likelihood that that's going to revolvulize. You want to give them a couple days, and then that hospitalization, you want to take them back and you want to do a sigmoid colectomy, right? So why do we decompress them first?
Size mismatch.
Size mismatch, right? Huge problem, right? So you try and resect to bowel edges that were ischemic, right? It's volvulized, so you've got ischemic edges. Hard to recognize where that ischemia ends. Maybe you've got clotting of the venous outflow, and you just put together a compromised anastomosis. It's a setup for a leak. So you would definitely prefer to decompress them, and Tommy was spot on. If we don't have the option of decompression, I have to operate on them that night. They're probably almost certainly getting the Hartmans out of me because I just don't have it in me to watch people go through a leak that I know is probably going to happen. So, cephal volvulus, you also have the option of trying to detorse them, right? So you can find your favorite gastroenterologist and say, hey, can you give it a shot? Occasionally, they will get it detorsed, and the reason to do that is exactly the same, right? You've got ischemic edges. Hard to tell the difference between healthy and ischemic. And by getting them detorsed, you can decrease the likelihood they're going to leak. You don't really have, your only option for an ostomy, if it's a cephal volvulus, is going to be an ileostomy, right? So the flip side of that is that a leak at a right colectomy, much less likely than a leak at a so that your leak rate goes higher the more distal you go, right? Okay. Probably related to lumen size, also related to a lot of factors that we don't fully understand. So this is, what kind of volvulus is this?
Sigmoid.
And you know that because of
He's pointing towards
the direction of the point, right? Right. So it's pointing to the right upper quadrant. It's a sigmoid volvulus. What's this one? Sacrovolvulus, that's right. And you know because of the direction of the point, right? What's a bascule? This is a tough one to understand. What's a bascule?
It's when the cecum holds on itself.
That's right. So Tommy's on fire. Who are you?
Because I had that consult with
I know.
Twice.
I know.
Twice, yeah.
So cecal bascule is the cecum, again related to a floppy cecum, but instead of twisting, the cecum has folded up and over on itself. So here you got your ascending colon, and then the cecum, instead of torsing, is basically just flopped up this way. So this isn't a surgical emergency, right? This is just an obstruction. There's this cecum is not compromised, right? You can see how the blood supply is not being. It's just you're still closing off the lumen of the intestine, so it's an obstruction, but you're not really. And it booted me again. But you're not really at risk of infarction. So, what's the treatment for a cecal bascule? We'll wrap it up with this.
So,
Historically, what was the treatment, Tommy?
historically, we went to present it.
Not historically. That wasn't the historic treatment for vascular.
Oh, the cecopexy.
Cecopexy or Ruel did say it. Cecostomy. Same principle, right? So a cecostomy tube, they would use it. You could use it for lavage. You could use it for, lots of things. Decompression. You could use it. But really, what it was being used for, the setting of vascular, it was being used to tack the cecum to the abdominal wall. Why don't we use it anymore? Because what?
So they're gross.
They are disgusting.
Oh yeah, that lady. Yeah.
That was awful. Did you use the appendix?
It wasn't for super vascular.
Why don't we do it anymore?
So cecopexy doesn't work.
It just doesn't work. I mean, just plain doesn't work. The recurrence rate is so it fixes the immediate problem. It may last a few months, but it almost invariably recurs very quickly. So I did have more. I'm going to stop here because it's been an hour. Any questions? Have I bored you to tears? It's 5 o'clock. You want to go home? Nothing? All right.
Is this my home?
Great. All right, guys. Good day. Thanks for hearing me. Hope. Don't be afraid to call. Have a good night. Almost over. Oh, it's her day off. That's right.
No, she
Oh,
was.
no,
She didn't want. Oh, no.